Yes, good to
At
have
least
you.
it's virtual this year, and it's not canceled, so we're here. Okay, so let me just share my screen here, and we'll get started. Okay. All right. Hopefully everyone can see this okay. So today, what I want to talk about with you guys is just telerehab in general and how it relates to someone with a brain injury, how we teach someone after they've suffered from something catastrophic, and how we teach them using a virtual platform. And so to backtrack a little bit, our program is kind of under the umbrella of QLI. QLI is located in Omaha, Nebraska. We're a post-acute rehab hospital. Um, our campus is here in Omaha, and it's a residential facility, and so the folks actually are living on campus while they're getting rehab. And so I work with OT, PT, and psychology, and we provide telerehab here on campus as well. So kind of like to provide that continuum of services after someone leaves our inpatient facility. So this is just a quote that I wanted to start with. It says, "The world as we have created it is a process of our thinking. It cannot be changed without changing our thinking." I think this relates very well to just the past year and having to change our thinking in regards to everyday life, and especially just technology. It's something that we've had to get used to using, whether we want to or not. It's going to be in our lives probably here on forward. And so, how can we turn that into a positive thing, and how can we use that and utilize it to our best ability? So the objectives for this presentation: understand various concepts of learning following a neurological injury, discuss variables of learning in relation to a telehealth service delivery model, identify individuals who are appropriate for receiving telerehab services, understand the interdisciplinary approach when providing virtual services. So we're kind of Office fans here. You'll see a couple memes of Steve Carell. Telerehab, the future is here. So, like I said before, this is something that we're probably going to have to get used to with use of technology, whether we like it or not. Our telerehab program actually wasn't in light of COVID. We had started this program before COVID even happened, and we were serving those across the United States. Myself and the rest of the clinicians all hold licenses all over the United States to best serve these individuals, and I'll get into more of that later on in this presentation. But like it says, the future is here, and access to expertise and specialty care, like I said, there's a lot of individuals out there that have traumatic brain injuries, but they don't have the access to expertise. And so we want to be able to provide that access and that expertise to those individuals who might live in rural areas, or they might live in a community where they do have access to care, but maybe not the expertise that they need for the complexity of their injury. Like I said a little earlier, continuation of care. Not only do we provide a lot of care for those individuals that are leaving QLI's campus, but also just leaving post-acute rehab in general. And so we're kind of that transition when someone gets home. And so that leads into the next point of contextual training in someone's environment. We get the joy of treating someone in their own homes and in their own environments. And how convenient is that they don't have to, if they're maybe in a wheelchair, they don't have to pack up their wheelchair and try to get to their appointment on time. They can just do that from home. But also, it's very contextual in the fact that we're training these individuals in what makes sense. So, if they're working on stairs, why wouldn't we use the stairs that are in your own home versus going to a clinic and practicing there? From a speech standpoint, why are we could be naming things in your own environment that you commonly talk about rather than just items pulled out of a box. And so one of the things that's very important to think about is how contextual it is for these individuals. Reduced travel time and cost, like I mentioned. Improved compliance. We've found that some people are more reliable and more open to showing up to sessions where they don't have to get anywhere. They can just log on straight from home. And then lastly, accountability and responsibility, kind of with the compliance piece. But a lot of these individuals just think that, when they're at home, they hold themselves accountable a little bit better. So as with everything, there's always some barriers. And so this is just what we talk about as far as barriers to adoption. So maybe what are some of the reasons that tele-rehab might not be for everyone? And what are some things just to think about? So, traditional therapy, I think as much as we talk about contextual and functional and the importance of serving someone and providing care in someone's environment, there's also going to be benefit to traditional therapy. In a lot of circumstances, doing traditional therapy is always going to be helpful. And so that was one of the things that we're thinking about, and not that we don't do that, but I think that's just a gap there too. Unsure of capabilities. I think we get tons of questions as far as, well, how are you going to do physical therapy virtually? How are you possibly going to do OT virtually? I think speech can be a little bit more straightforward. But I think thinking about a traumatic brain injury, a lot of times I'm not working on speech, I'm working on memory, I'm working on attention, I'm working on executive functioning. And so it's really important that I do that in someone's own environment, and same with PTOT. And we have to get really creative with a lot of those things. And we've had to get creative in the use of someone's caregivers or family members to help incorporate a lot of the things that we're doing. Quality of care and objectivity. I think objectivity is one that I really want to point out, that it's just been hard, especially recently, in regards to finding objective measures. Using virtual tests, I know from the speech standpoint that it's been hard to find virtual assessments and things that are more quantitative. And so getting those measures has been a little bit more difficult than when I used to treat in person. Supporting outcome measures, kind of the same thing that I just talked about. Just getting numbers, I think that can be really hard virtually, but I think there's a lot of progress, and I think each of our associations are doing a lot of back end work to come up with these things, knowing that technology is going to be something that we're using from here on out. And so I think every discipline is getting better at finding different ways to measure progress. Technology, everyone knows that technology can fail, and so that's just one of the things that we've had to get used to. Sometimes someone will have a good connection, they can't get logged on. People that aren't familiar with technology, I've had a lot of those folks, and throw a brain injury on top of it, and it can get a little harder. And so, I think just being patient, and a lot of times we'll get it to work, but having that caregiver or some other support there can be really helpful for some of those situations. And then the last one is just public policy, regulation, and funding. This is something that's always changing per discipline as well. I know for me, I've just had to stay involved with my state's legislator and what is going on as far as compacts and licensure, and who is funding what. I know right now, from a tele-rehab standpoint, that funding is just not getting covered. A lot of things aren't getting covered right now, especially after COVID. Insurances are deciding that they're not going to cover individuals that are seen virtually. And so I think that's just something that each of us need to keep in mind and to advocate for in our own state, and making sure that we're bringing up questions and letting them know the importance of technology and using this. So like I had said earlier, I wanted to talk about the principles of learning. So after someone has had a brain injury, they're going to learn a little differently. And so we have come up with what we call the principles of learning. The first one is training is specific and contextual. Training is specific and contextual. So what I mean by that is it's specific to the task. So if you're going to be working on something, make it specific and make it contextual. For example, I have a neurologist that I work with, and she had severe aphasia. Well, rather than having her just read an article randomly that I found, I had her read research articles. And then I had her start listening to different CEUs that she had to get. That was something that was very specific to what she was needing to focus on. Consistent and adequate support. We want to make sure that we're providing as much support initially as possible, and then reducing that as needed. And so one of the things that comes in that we found to be super helpful is just the training the trainer. So the caregiver family members. We want to really make sure that we're training those individuals so that they can help provide the support that we're doing in those sessions. If we get 60 minutes, 90 minutes with someone a week, that's just not going to be enough. And so how can we be helpful in training those around them to carry out what we're doing in our sessions? And that ties into just repetition of formal and functional therapy. How are they consistently getting repetition throughout their day with everything that they might be doing? So really just finding that is super important, that we're training those around them to help carry out a lot of these things, given that, a lot of these individuals, their memory might be a challenge, their reasoning might be a challenge. And so if they don't have those in place, how are they going to remember, one, how to do the activity, and two, to follow through with it? They're going to need someone else to be that external support. And then the last one, sufficient intensity and complexity to promote recovery. So often what we say is push yourself to the edge of your ability, right? So I'm not going to let you do something that's super easy for you, but I also don't want to do something that you're going to fail at every single time. So we want to make sure that we're providing the right intensity to promote the maximum amount of recovery. So next we want to talk a little bit about our process. So when we're thinking about, who is appropriate for telerehab, pretty much everyone. We think who could you serve virtually? And I think the one thing that we've learned is think about that you could serve everyone and then kind of work your way down. So, and when we're thinking about who are we getting from all over the United States, who are we getting from QLI, anyone that's appropriate for outpatient therapy should be appropriate for telerehab. And like I said earlier, maybe there's times where it's not, but for the most part, we've found that we can do pretty much everything that a 4-walled clinic might be doing. The people that we're serving, brain injury, spinal cord injury, other neurological injuries such as stroke, amputation and limb loss, and then another one that we've added onto here is a couple pain folks as well. We want to make sure that what we're doing, like I've said before, is very specific to a client's needs. So before COVID happened, we were going in person to do assessments. We were flying to wherever that person might be or driving, and we were doing those in that person's home just to give us a really good idea of everyday life for that individual. Obviously, right now, that's not an option, and so we've had to get really creative with how we're doing assessments virtually. And I think that we've gotten pretty good at utilizing what we have and the assessments that we have to get a pretty good idea. And that's often talking to family members, that's talking to caregivers. And I think we found that we've established some pretty good relationships with a lot of these individuals, even though we don't see them in person. You're in their home, and so you get to see a lot. And believe me, I've seen a lot of things. So I think we've found that we can get very, very specific to the client's needs just because, we're in their home at all times. So, like I said earlier, what we have through our telerehab services is OT, PT, speech, and psychology. One other thing that I kind of mentioned earlier is considerations for an appropriate referral, a community-based level of care. They have to be able to be active in their community. Back home is where we're seeing these individuals. Rural versus metropolitan location. Like I said, I think we've had some individuals where they're in the middle of nowhere, and that makes sense. So virtual therapy makes sense because, the closest clinic might be hours away. But we've also had folks that, are in places where they do have access to therapy, but it's not to the expertise that they need. So one example is we had a guy that was actually in Chicago. And as you can imagine, there's tons of therapy options in Chicago, but they benefited more from just having someone in their actual home environment and teaching okay, how do we do a transfer in our home, like in our bathroom? How are we going to do ADLs in the bedroom? So a lot of those things that just made more sense. And then caregiver clinician consultation, like I've been saying, just the importance of coaching that caregiver when you're in your session so that they can be carrying out all of those skills outside of your time. So in regards to just video conferencing, we use a Zoom platform, so just like this. That's HIPAA compliant. We have video recording capabilities. I think that's something that I've found to be super helpful is the ability to record. So in regards to speech, I can record someone and then from audio feedback, they can go back and they can listen to how they're doing. I think our PTs and OTs have found that to be super helpful as well as just that recording capability. So they can go back and they can show someone the progress that they've been making, which I think is also really helpful. One of the things that I've also really benefited from is just the ability to one, share my screen into the whiteboard on Zoom. I think you've all probably used that by this point, but something that I've also found to be really helpful. And I'm kind of excited to see where technology goes in regards to different platforms and the capabilities here in the future. I think we'll be seeing a lot more things coming up. So some of these are just things that we often send with people or make sure that they have in order to start therapy with them. And so often just using a phone or tablet, a laptop. A lot of these individuals, like I said, they're using them in their own environment. So if I'm going with someone to a work site, like I'm helping someone get back to work, they're taking their iPad or their phone with them. Making sure that they have cellular data so that they can be using that wherever they might be. You know, I've done a session in a grocery store. So can this person safely access a grocery store? Can they refer to their grocery list? They're using that in there. So I actually just had someone put their iPad up in a grocery cart and I just watched them go throughout the grocery store. And that was something that was easy for me to see their safety and awareness and things like that. Devices and mounts, we often send mounts with these folks too, so that they can just set it up, and especially for like a physical therapy session, they can set it up, and then our PT can be coaching them throughout that session. Wireless headphones, obviously, just from an ethical standpoint, we want to make sure that you know we're keeping these people safe, and so we have wireless headphones that we have, and often the clients have, especially if they're in a community surrounded by other people too. And then just remote site requirements, I think like we've talked about, whether it be HIPAA compliance, whether it be that they have cellular data available, all of those things being important too. And this is just a quote that kind of wraps up a little bit about what I had talked about earlier, just connecting therapy to life, making it meaningful, individual, and engaging. So like I said, if the task is meaningful, if it's motivational for the person, they're more likely to probably follow through with that and actually do it. And so when it's in their own environment, we've found that it can be a lot more meaningful and motivational to that individual, which in that case, we see a lot more progress that way too. Just some clinical principles, I think, to think about. You know, when you're doing an in-person session versus when you're doing it on a computer, there's a lot of things that you have to keep in mind. I think have found too, just we've recorded ourselves and just noticed that like you can definitely tell when someone is not paying attention or when a clinician might be on their phone or something like that. And so just making sure that you're appropriate, I guess, in your sessions and making sure that you're prepared this first one. When I first started tele-rehab, I thought it was going to be just like inpatient where you bring your kind of toolbox of items and you know what you're going to do. But when I first started doing it on a screen, wow, it was so much different. You may have your toolbox of items that you want to do, but it's not probably going to work across a computer screen. So you're going to have to come prepared with each session, especially if you're just starting. I usually had 2 to 3 things with each individual that I had in mind in case one failed. And now that I've been doing it for a while, it's gotten a lot easier, obviously. But camera and orientation, making sure that you're in a good clinical setting, that it's not a distracting environment, not super noisy. I will say that there's been times, and speaking of environmental considerations, where I've been in a louder environment, and some of those people with attention deficits, that's a hard thing for them. And sometimes it's actually a good assessment, but for the most part, making sure that you're just in an appropriate space too. And then technology training, IT troubleshooting, that's just one of those things, like, we all have that person who doesn't understand technology that well. And so how are we doing that training on the front end? A lot of times we will have someone in the tele-rehab group, and they will be meeting with families prior to demonstrating how to use the iPad, how to use Zoom, how are they going to be receiving emails about our sessions. Those are all things that we're trying to do on the front end, so that when we actually get to see them as clinicians, we don't have to spend a ton of time doing that. But like I said, obviously that comes up, and there's always times where you're going to have to help troubleshoot. And so knowing your platform and knowing how it works is super important. And I would suggest highly of trying to do this on your own too. So act like you're the client, and what does the screen look like? What are things that you might see, so that you can walk them step by step on how to access different technology in the platform. So I just want to walk through a little bit of the disciplines that we do have and some of the things that they're doing during their sessions. So first is occupational therapy. And so our OT, Melissa, she's doing a lot of independent living skills, vision, environmental accessibility and adaptation, adaptive device and accessibility recommendations and training. She's done a lot of that in regards to just looking at a person's home, making it adaptable to what they might need. And that doesn't mean that we can't also go to that person's home too, if we need to, rather than do that virtually, to provide some of that education training and making sure that their home is safe and accessible. And then fine motor and sensory integration training as well. So she covers a lot of different things. And so I think some of these are harder to understand how you do virtually more than others. But like I've said before, she gets really creative in her ways that she's able to do a lot of these things. From a PT standpoint, a little bit more straightforward, but I think for a lot of our folks, obviously they're coming from a more post-acute rehab, and so they're at this point where we want to work more on endurance, balance, more of those high-level physical activities. Also, movement disorders, musculoskeletal impairments, pain treatment. Like I mentioned, we've had a couple people go through our programs that are more pain-related. And Brad, our PT, does an incredible job of just coaching them on that, and then also caregivers on that too. And then just overall health and wellness. I think we've found there's a lot of different tools that we can use from a PT standpoint too, and just technology overall. I think one of the things, for example, is just an Apple Watch. So we've been trying to connect with them on how can we use that as far as like detecting falls, monitoring heart rate, looking at, the activity. He also uses an app on an iPad in order to set up home programs. And that's also something that he can monitor from his own iPad to see, is this person following through with their workouts? And so he's gotten really creative in just the ways that he's continuing to get repetition outside of his sessions too, and making sure that happens. One example of just, I think, endurance and balance and gait training is we had a guy out in Colorado, and he was working on walking without a walker. And one thing he had him do is just use hiking sticks, and they went out onto a trail, and his caregiver was holding the iPad, and our PT was training him on how to hike out in Colorado, which was pretty cool. And then from a speech therapy standpoint, again, I think that it can be straightforward, especially in regards to expressive and receptive speech. So that's something that isn't too hard to do. They don't have to be anywhere special. I think that that's something you could do in person or virtually. But I do think that it does matter as far as, what is it that you are treating, and is that motivational, and is that tied to the specific task that person wants to get back to. AAC training, that's something that I continue to look at and try to educate myself on, because there's just not a lot on that piece, especially from a tele-rehab standpoint. Um, One thing that I've found to be helpful is just sharing the person's screen. So say that they might have an iPad that they're using. If they can share their screen with me and they have a caregiver with them, then I can really see what their AAC maybe application looks like. And we'll work on like receptive, expressive tasks. Are they clicking on the right key in order to express their wants and needs? And so that's something also that I've had to get pretty creative with. One thing that I think we'll have to keep looking into is just more of those more complex AAC devices, and how we can be helpful with some of those as well. And then, like I mentioned, cognitive rehabilitation. So that executive functioning piece, memory, problem solving, you get to see a lot when someone is at home. And so I will say that it's pretty good to be able to see what are they doing in their free time. Are they initiating anything day to day? What does their memory compensation look like? Do they have a schedule that they're following? Sometimes we'll do cooking with people, and that's a good way to assess kind of that divided attention and safety. So we'll do that in someone's home. So you can get really creative with a lot of the things that you're doing. Life skills training. This is a big one. I get a lot of people that are, obviously post-hospital, some young people that are working on getting back to school, getting back to work. And so think of all of the cognitive pieces that are involved in that. You're going to have to manage your time. You're going to have to put in your calendar what are the, especially if they're going back to school. I have homework. When am I going to be doing this? When am I going to get it completed? How am I going to plan and organize my time around that? If I'm going to live independently, these are all the things that I need to do. If I need to budget, if I need to get groceries every week, those are just all things that I think people take for granted because we do that every day. But these people are all relearning how to do these things. And for some of them, if they're newly graduated and going to college, they're learning it for the first time with a brain injury on top of it. So it makes it a little bit more complicated, but it's a good challenge. And then the last one is this exploration of purposeful daily activities. So I think for a lot of these folks, they tend to leave the hospital and they're going home and they're like, now what do we do? Then their whole lives are just based on therapy. They have been for the past maybe 6 months to a year. And so what are we doing to motivate these folks, whether that be volunteering, whether that be work, other things in their community? I know with COVID, we've had to get really creative with how can we keep these folks busy and can they be involved in their communities. And so there are some things online that we've been able to find that people can volunteer for or, get involved with, but still can be a little difficult at this point. But I think just the importance of, therapy isn't a person's life. And so how can we make this as their schedules and their days as purposeful as possible and getting them back to what they really want to do and what their lives were before. And then lastly, just psychology. I think we have found that having psychology on board is super important. When someone has suffered from a catastrophic injury, their lives have been changed, not only theirs, but their families. And so a lot of those family dynamics and social relationships have been impacted. And so we have found that almost with everyone, we recommend psychology, whether they're not, a lot of people aren't necessarily open to it in the beginning, but I think that we found that it can be super helpful. And a lot of folks have just said to us, wow, just being able to talk to someone that's not my mom, not my wife, can be really, really helpful. And just walking them through some of that maybe anxiety or frustration and how do I cope with the situation that I have now. So lastly, I want to show you guys some videos that we've taken just to give you a little bit more maybe knowledge about what it is that we do and how do we make this as functional as possible. So I'll play this video for you. So this is Dipka. She is actually based out of California. And like we've said, she had access to therapy, but wanted to utilize us just because she wanted to be at home in lieu of COVID. And thought that something like this would be very functional. So as you can see, she's using the H200. It's like an E-stem unit for her hand, and that is helping her in order to open up those fingers in order to fold her laundry. And then you'll see that her aide is standing next to her as well to give some instruction. Next guy you'll see, this is Kevin. He is based out of Tennessee. He is a dad with 2 little kids. He was in a car accident, and so what we're working on with him in this video, you'll see just some balance, fine balance. He has that walker, but what he's working on, you'll see that the aide is right next to him. Our PT is coaching the aide on what support to be providing him. And he's just working on going back and forth in his kitchen and accessing his kitchen. And then I believe this is the last one. This is a speech session that I had. This guy was pretty apraxic, also very aphasic. And so we're just working on naming common objects. So the objects that I'm holding up, he actually had the same ones in his home. And so we're just working on saying these. So just a speech therapy task.
So Nealey, we're just not hearing anything if there is sound you wanted us to be hearing.
Okay, let me see. Let me start it over.
Toothbrush.
How about that?
Tooth.
Yes, now we can hear.
Good job.
Good job, Moses. What is this? Comb.
Comb.
One more time.
Go.
Good. Let's go back to this one. What is this?
Comb. Cup.
What is this one again?
Yeah, toothbrush.
Nice. Cool.
Comb.
Good.
So as you can, that was Marvin. He was pretty funny. He was one of those guys that really did not like telerehab to begin with, but formed a pretty good relationship with him, and he got to the point where I didn't have to give him that initial sound, that initial phonemic cue, and so he got to the point where he was able to at least say the objects on his own, which was pretty cool to see. So lastly, I'm just going to leave you guys with a video, and once this is over, I will be open to any questions you guys might have. Okay.
Any questions? You can type them in the chat or the Q&A box, either one. That's what you guys see on your end.
I don't think I see any.
I know. Nobody? Nothing? Oh, here we go. How do you handle cognitive treatment with Medicare?
That is a great question. And we are working on Medicare getting reimbursed for it. We don't actually serve Medicare right now. And so right now we are doing work comp and private insurance. But Medicaid and Medicare are a couple of things that we're working on, just getting reimbursed for that. We found not only telehealth, but inpatient, it's hard to get reimbursed for. And so we're working on that.
Do the clients have to have their own devices and iPads and things, or are they provided devices if they don't have them?
Often if they do not have any, we do provide them. We'll send them home with an iPad. It's just like a mini iPad that we'll send them with a mount. And so, but a lot of times everyone has a smartphone that they can use. If they don't have that, it seems like everyone has an iPad now. And so, most of the times it's not an issue, but if they don't have anything, yep, we do send that.
Please address issues of therapists and licensure across state lines.
So as far as licensure, right now, at least for speech therapists, you need to be licensed in the state you're providing care. Yes. So if I'm in Nebraska and I'm serving someone in what was that? Can you go through two? So I'll answer the first one of, do you need to be licensed in the state you're providing care? Yes. So if I'm in Nebraska and the person is living in Iowa, I have to be licensed in Iowa. So I'm licensed in probably like 35 states right now. And so I'm licensed in all of those. Now, one of the things that's been hard, I think, is just like I had mentioned, compact licenses. And so OT and speech are two of the disciplines that right now, I don't believe there's compact, at least for OT, but for speech there isn't. And so we're really working with our states in order to do that. In speech, there has to be 10 states that have agreed to the compact in order to do that, which would make our lives a lot easier, I would say. And so, but for PT, there is a compact, and I believe for psychology there is as well. So like I said before, I just reach out to my state and to the legislator and keep updating them and bugging them on that. And then Carly, did you see one about slides 2 through 6?
I do. It says, can you go through slides 2 to 6 on the posted PowerPoint? So I just wonder if is there maybe a little bit of a difference from what you presented to what we put on the website? Is that why? I'm opening up our website, the website version right now. It's just my computer is
It says there is a difference, is what somebody adds.
Oh,
okay. There may
see
have
here.
been.
So 2 through 6, on the other one, you have like the quote from Anders Ericsson.
Mm-hmm.
And then you have the concepts of learning.
Right.
And consider the variables kind of stuff. And then memory, reasoning, and explicit learning.
Yeah, I think that some of those might just be switched around. And there might have been a couple that we actually ended up taking out. I think, let me share my screen here so that I can show you. As far as this one might be different. So we did put in a new learning principles one. Rather than the explicit implicit learning, that's more focused on memory. So when we're talking about someone with a brain injury, a lot of times we talk about two types of memory. We have our explicit and implicit. Someone that's had a brain injury is often going to learn through explicit learning. So to learn explicitly, you kind of have to have reasoning and memory intact. A lot of times they're not when you have had a brain injury. So that's why we teach through implicit routines, implicit learning. by incorporating these learning principles, if that makes sense. So some of those slides just might be rearranged, or there might have been more added. I apologize for that.
Any other questions?
Do you always wear a headset? It kind of just depends. Not all the time. I will say, just given our environment here, if I'm at QLI, sometimes there's people getting treated outside my door, and so I'll wear a headset just to be helpful. But otherwise, no, not all the time. And try the noise canceling ones. I think we've tried a ton of different headsets, and we have a special pair of noise canceling ones, but also just the Apple AirPods work pretty well too.
Is there a liability for PTs to be working on balance and stairs remotely?
You know, when they're working with someone remotely, we haven't had any concerns with that as far as liability issues. You know, if that person is with a caregiver or with, you know, there have been instances where someone has fallen, and that's something where if it's like a work comp case, we're reporting that to their case manager right away. Or, you know, if it was a bad fall, they're going to the hospital. I will say that there haven't been any liability issues so far, but, you know, we're having them sign things before they leave too. So we're not just sending them off, we're having them sign forms too.
Sure. Do you ever have no-shows, and if so, how do you manage that?
Yes. I think like with every outpatient, that does happen.
Sure.
So, I mean, we just try to reschedule as best as we can. Our schedules are pretty full, but if we're able to fit them in at a different time, we do that. I think we're consistently talking about, as our schedules get more full, how are we going to handle if someone doesn't show up like 5 times in a row? You know, we definitely want to be able to provide therapy if we can, but if they're not finding it motivational, or if they're not finding it to be helpful, then we do try to have conversations with whether that be a case manager or someone else about why is this happening, and try to get to the bottom of it.
Sure. Can you talk about how you do assessments?
So at least from my side of things, I use a few different assessments. And so depending on if it's in person or whether it's virtual, I have my own that I've kind of built. And it's actually one that I found, and it's not standardized. So a lot of times I'm taking their psychology notes, and if they've had a recent neuropsych exam, I'm using a lot of that information. One of the other ones that I've done, and it's not something that's online, but it's easy to get virtually, is the R-bands. And then just ones like the MOCA, the slums. Our OTs use the MOCA and the slums too. And then they have a few that they're using. I just don't know the names of that. I know our PT uses the bird balance, but I think there's a couple other uses as well that I'd have to ask.
Nice. How large is your residential facility, and how many therapists do you have? And do some of them only do telehealth and some inpatient, or how do you guys manage it, I guess?
Right. So our residential facility is a 60-acre campus. We have 6 houses with about 10 rooms in each of those. And those can be full, they fluctuate. And so as far as therapists, I'm the only speech therapist that is incorporated in the tele-rehab program. Other than that, we have 4 others that are working strictly just on inpatient. The hard thing, we would have more, but with licensure, it's just really hard to be able to have more at this time.
Sure. Can you add more on types of people for tele-rehab services? Can it be counseling sessions?
Like, can it strictly just be counseling?
Yeah, that's the way I'm kind of reading that, Doris. If I'm saying that wrong, you can correct me, but yeah, can you add more on types of think just, yeah, like how many different therapists can you have doing tele-rehab maybe is what.
Well, for us, we have 2 OTs, we have a PT, myself, and we have 2 psychologists. We don't do sessions together, maybe that's what they're asking. So we don't do a lot of collaborating together on the same session. We do, I mean, we're obviously in the same proximity, so we're talking back and forth all the time about a person's program, but not a lot of co-treating.
Okay. So she was asking counseling alone. They can get counseling via tele-rehab?
Sorry, yes, yep. And we found with psychology too, if they can't get licensed or it's really hard to get licensed, it's easier to get a counseling license. And so they'll sometimes just do counseling rather than psychologist, I guess.
Someone's wondering how long your typical stay is for residents, for residential.
Well, for tele-rehab, it's about 3 months. So anywhere from, I would say, 3 to 6 months. We have seen someone for like a year. Residentially here at QLI, that can kind of fluctuate to probably anywhere from, like I said, 3 to 6 months probably. But obviously that's dependent on insurance as well for how long we get to keep those folks.
Okay. Does rec therapy ever get involved and or reimbursed?
We don't have a rec therapist
Okay.
on our team, but we have a rec therapist here at QLI that we consultate with. They don't get reimbursed for them, but we're consulting with them.
Okay. They're wondering if you can repeat those assessments you listed off. Sorry.
Yeah, you're good. So the one I don't even have a name for because it's just out of a speech assessment tool, and I combined a bunch of them. So it's not standardized. But the other one is the RBANS, RBANS, all capitalized. The other one is the MOCA, and then the slums. Those are 3. And, those are more like screeners, the last 2.
Yeah, and we just wanted to mention too, there's the Combi site. If you even just Google COMBI, a lot of brain injury specific assessments that are free anyways will come up for you. I don't know how many speech necessarily, but I mean, they kind of address all.
Yeah, so the
areas.
Combi website is paid for out of the Brain Injury National Rehab Grant, and so it's where all the brain injury model systems and that put all of their different assessments and screeners. And so they've done a job of just gathering all of the different assessments and screens out there related to brain injury. And they even do have ones that are proprietary. They just, in their state, they're proprietary, but then free. And COMBI stands for the Center of Brain Injury Measurement. So, yeah, you just Google it, and then they just have, the different scales and all of that. So it's a great resource for anybody working with individuals with brain injury. You can go in there and look at different, if there's something that you're wanting, like whether it be cognition or fatigue or different thing, you can kind of search based on what type of assessment you're looking at.
That's good to know. I haven't heard of that.
Yeah, it's a good resource. Yeah. Somebody else asked, do you choose telehealth over outpatient sessions considering the functional benefits of therapy in their own environment? Or is telehealth only provided due to distance?
No, I think like I've said before, it's not necessarily due to distance. I think a lot of these folks have had the ability to go to somewhere that even might be kind of close to them. It's just hard to find people that know brain injury. They're also different, of course. And so having the access to expertise is, I think, something that we have found that people find helpful.
Right, good. Once you discharge someone to home, do you have them physically return for recheck?
We don't have them return, no. So like if they're leaving QLI, they don't return back for a check at that time. Once they go home, we expect that they would establish a primary care physician, a psychologist, if they're using us. We're obviously here. Some of the folks I have had maybe their case managers or family want them to get reassessed for a neuropsych. And so we'll reach out to someone just in their either home community, or if they're available, I've had a couple come back here to QLI to get reassessed by our neuropsychologist.
Getting some more here. You get lots today. Can therapy be once a week? Or maybe talk about like a typical.
Yep, I think it can. I think it can. It's also just dependent on the person's needs. So there is someone that I see once a week, and that's more just a check-in. I was seeing them obviously for a lot longer before, maybe 5 times a week, and now we've gotten to the point where they don't need me as much, which is good. I think sometimes our clients are like, why are you decreasing me? And it's like, it's a good thing. You don't need me anymore. And so I say typically, though, I see people probably 3 or 4 times a week for 30 to 60 minutes.
Someone else, Marie, is wondering, do you have nurses or doctors on your campus?
On our campus, yes. So we have nurses and a physician here on QLI's campus. However, given that tele-rehab is a separate entity, we do not. And so we're relying on that person because a lot of times they're not in Omaha, they're somewhere else in the country. And so they establish a primary care physician there. And we usually are pretty involved in that as well. So we have reached out to doctors, physicians, surgeons, anyone that we can be helpful in sharing information with.
Great. So this one's got a lot of components, but kind of just your history of QLI. How do folks find you? Is it just by chance, or do you, like, how does the marketing part work? Do you go through different brain injury associations? And how long have you been in existence?
QLI, oh my, I would have to.
Isn't it like the 70s? Isn't it in that one book? No.
Like 28 years is how long that we've been here. So, a lot of times, what's kind of sad is people a lot of times don't know about us until they have to know about us. But that we have a website you can obviously find us on. We have really good relationships, I would say, with a lot of the more acute hospitals. So like a Madonna here in Nebraska, Craig Hospital in Denver, Shirley Ryan in Chicago, Shepherd's. So we get a lot of referrals from there. But if you want to reach out to us, you have my information. There's also, like I said, we have a website with all of our information on it as well. And there's a link on there to get a hold of our admissions. So the process is like, usually our admissions liaison will go out and they will assess someone. They'll see if they're appropriate to come to QLI's campus. And then we'll kind of go through that process.
Do you personally see people for telehealth only, or do you have only patients that have been discharged? If yes, how do those patients find you? So if you only see telehealth, how do they find you?
I would say that's kind of word of mouth, as far as at first we were taking only workman's comp as our form of reimbursement, just because we were finding that to be more reliable. But we have a lot of good relationships with a lot of the work comp business out there. And so a lot of that is just good relationships with case managers and those companies. But then other than that, if it's like a private insurance, we have folks here that are incredible, and they're really just calling them and seeing if we can get reimbursed for this person. And so kind of that's the process for that. I think there was another part of that question that I might be missing.
Sorry, I think just kind of like, do you guys work with other brain injury associations?
I would say that we're involved with, actually, I've given a presentation recently for Iowa Brain Injury Association, Missouri, now this one, Colorado. So I would say probably in the surrounding states. Yeah, but I think there's a lot more involvement that we could have. I will say that it seems like the brain injury networks have a lot of resources that even our folks and we aren't utilizing probably as much as we could be.
Good. Marie Brecken just said, QLI is a great facility that we refer patients to. Thanks for a great presentation.
Well, thank you. It's a wonderful place.
Yes, we've heard only good things too. So
If
Yeah.
anyone ever has a chance to come, I would highly encourage it. It's kind of the Disney World of rehab.
Sure, sure. I think that's a good segue to end unless there's no more last minute questions for Nealey, but otherwise we will head off to break.
Well,
You all know
thanks,
how I
guys.
get a hold of her, so thank you so much for your time today. That was great information, good ideas.
Yes.
Okay.
Well, thank you. Thank you for having me. And yeah, like I said, my information's on there. If you guys have any more questions, reach out.
So one woman said her son was there in 2009 and 10, and she said a most positive environment at QLI.
Oh, that's nice. It's good, it's good to hear some of those things. So
Yes. Yeah. Good. Okay. Thanks so much. All right, guys, you get a break until 2:30. So at 2:30 we'll come back and